Good evening. Thank you for joining us for Points About Joints with Adina Orthopedics. I'm Dr. Brad Strauch, a sports medicine physician with Adina Bone and Joint Center. As your healthcare partner at Adina Orthopedics, we work with patients to find their best orthopedic care for solutions and conditions like arthritis, sports injuries, hip pain, knee pain, and more. Today, we're going to focus on joint pain, their causes, the anterior hip approach for a total hip replacement, treatment options, and what you can expect before, during, and after a total joint replacement. We encourage viewers to submit questions, which will be answered by our panel after their remarks. Joining us today, we have Dr. Neil Patel, orthopedic surgeon with Adina Bone and Joint Center. Welcome, Dr. Patel.
Well, thank you so much for having me. I really appreciate it.
Sure. Please tell us a little bit about yourself before we get started.
Sure. My name is Neil Patel. I did most of my training in the East Coast, grew up in New Jersey, and did my training in Albany, New York, and then Westchester, New York. And I had the pleasure of doing my fellowship right here in Ohio with the GIS in New Albany. And now I had the pleasure of working here. I have family in Columbus, and it was it's been great so far.
Good, good. No, we've been happy to have you. Well, we'll get things kind of kicked off here with our first question. So first we're going to start out, what is joint pain? What causes it? And how can it affect one's quality of life?
Sure. Joint pain can occur from multiple causes. And the common denominator is that you have a joint that's made from cartilage, has meniscus, it has all these soft tissues. But as we age, we have wear and tear of those things, or we can have inflammation in the body that can cause a lot of wear and tear. And as you get wear and tear, unfortunately, you get into this cycle where the wear and tear causes more inflammation, more pain, and can lead to joint pain.
Mm-hmm. Okay. And are there specific things that we can do to prevent that pain from occurring?
Sure. And some of the things that we talk about is the things like gout, the bursitis, being overweight or obese, having repetitive tasks, repetitive strain on the body. So what we do is exactly the opposite of that, weight loss, if you have a little bit of overweight. And when we talk about knee replacements or knees in general, the knees in particular are very susceptible to weight loss. So as you lose even 10 pounds, your knees feel like you lost 40. The other thing is if you have chronic conditions like gout, you have chronic conditions like rheumatoid arthritis, you can manage those with medications now, and those can severely benefit the joint pain.
Sure, good. So arthritis, very common, affects 1 in 5 adults. What exactly causes arthritis, and what are the different types of arthritis out there?
There are so many different types of arthritis, but the 3 that we focus mainly on is osteoarthritis. And osteoarthritis is a good old-fashioned wear and tear arthritis, where you have repetitive tasks, repetitive things that you've been doing all your life. You start that wear and tear pattern of the knee, the hip, and that can lead to further inflammation, and that can lead to a lot of strain on the joint itself. The other thing is rheumatoid, where your body makes antibodies against your own body, and it can severely affect the cartilage on the joints, and can lead to a lot of inflammation. And then the third one is post-traumatic. It's when you have fractures or repetitive tasks, and that can lead to severe wear and tear. It just never heals properly and can cause a lot of damage and can lead to eventual arthritis.
Okay.
Mhm.
Very good. And I know I've had patients come in and they're worried which one of these is the crippling arthritis that patients are often concerned about when they come in.
Right. And there's a common denominator, all of it. And the common denominator is that inflammation.
Mhm.
And that inflammation really drives the pain. And there are 4 parts to that inflammation. One is pain. You get redness. You have warmth that comes with inflammation. And you get swelling. And we see this every day in all of our joints patients that exhibit all 4 symptoms.
Mhm. Yep. Many different presentations.
Mhm.
And not everybody's going to come in maybe with a lot of inflammation. Sometimes it's just the pain or the disability.
Correct.
But yeah, all those things that we see listed there, often they'll come in with. It's affecting them in every aspect
Absolutely.
of their life. So I'm a patient. I think that I have arthritis. I have some of those symptoms. I'm concerned that I might have arthritis. I'm not sure which type. It could be osteoarthritis, rheumatoid arthritis, psoriatic arthritis. What should I do if I'm concerned my joints hurt? Where do I go? What do I do?
Come see us. Come at Adina Bone and Joint. We will evaluate you, both Dr. Strauch and I. We have sports medicine, Dr. Strauch and myself, who is the joint surgeon, and we'll evaluate and see what kind of arthritis you have. If it's something that we can manage with pain medications or injections, we'll go that route. If it's something that requires a little bit more global management, like with rheumatoid arthritis, we'll refer you to a rheumatology, and so on and so forth. So come see us and let us take care of you, and we can go from there.
Sure. And nowadays we see on television all the time, there's a lot of advertisement for medications as it relates to rheumatoid arthritis. But the good news is which arthritis is actually the most common arthritis when patients are coming in.
And I would say the greatest advancement in the last 10 years has been those RA medications. It used to be the RA were really crippling type of arthritis, affect the spine, affect the joints in various different bodies. And my mother suffers from it too. But over the last, I would say 10, 20 years, when those medications really improved their quality of life. And now it's funny because now we see an osteoarthritis pattern in those RA patients. It's not just those very inflammatory rheumatoid type of arthritis. So
because
the greatest advancement, I think, in those anti-inflammatory medications.
Because they're actually modifying the disease, and so you don't get that destruction. And the good news is osteoarthritis is going to be the most common. So patients are maybe fearful. I don't want rheumatoid arthritis. That's the bad one in our minds. But most of the time, it's going to be osteoarthritis for these patients. All right. Well, next question. So luckily, many injuries that we see in arthritis can be treated without surgery. And we have a team of orthopedic specialists at Adina Bone and Joint Center. And that's our goal, is to treat patients, whether it be non-operative or operative, having you see the surgeon. But initially, it's usually going to be non-surgical treatment. So what are the various non-surgical treatment options that are available? And when would you recommend those treatments be instituted?
Sure. There are a whole host of non-surgical treatment, and we always want to start with the most benign, the one that's not going to affect you the most, and it's always going to be activity modification, because as we know, the most common type of arthritis is that simple wear and tear where you have increase in activity, and that can lead to that degeneration. And so activity modification is absolutely the first the line of defense against progressive arthritis. Then we can talk about heat and cold treatments. We can talk about anti-inflammatories, because I said before that this is an inflammation issue. And part of that anti-inflammatories are those oral medications, those creams. We can talk about things like ibuprofen. We can talk about things like diclofenac gel and creams like that. Then we have the injections that we can progress to. And with regards to knees, radiofrequency ablation works incredibly well. And even if you're thinking about surgery, if you're thinking about having those have really bad arthritis, but simply don't want to do it at this time because you don't have you're not medically up to it, we can buy you time with some of those treatments.
Mhm.
And they work really well.
Yeah. So say I'm a person that is very active
Mhm.
and I want to be able to exercise, but I have arthritis, and you're telling me, do I stop exercising?
Mhm.
What would your recommendation be? In
Right.
that scenario?
And the most important thing is to have that quality of life. The goal is to continue those activities, because what's life without them?
Mhm.
And so what we want to do is not to discourage you from not doing activities that's going to be beneficial for your overall health.
Mhm.
The goal is to control that inflammation, control that pain, so that you can do those activities
Sure.
and enjoy your life.
Yep. So we look at those other treatments there
Correct.
to kind of help you do the activities that you want to do.
Absolutely.
Okay. And so what are the benefit of non-surgical treatment options
Mhm.
when it comes to treating arthritis?
The biggest benefit is that you don't do surgery.
Yep.
And there's no such thing as small surgery. There's no such thing as benign surgery. Every surgery has some sort of an inherent risk.
Mhm.
And I'm a surgeon, I like surgery, but every surgery has risks. And what I tell my patients is that, the time for surgery is when it starts affecting that quality of life. The benefits of non-surgical treatments is that it can work for majority of people.
Mhm.
And that's what we start with. And people do really well. And a lot of times people simply do it, and they have pain once in a while, and they can go back to their activities.
And I know treating lots of arthritis patients, we definitely do the non-operative stuff. We do it as long as it helps a patient.
Mhm.
We do the medications, injections, bracing,
Right.
activity modification, and that may help them for many years
Right.
and put off their need for surgery. But say we've done all those things,
Mhm.
they're still having pain and it's really affecting their quality of life.
Right.
And it's time, when is it time then to consider a joint
Right.
replacement?
And that's exactly it. And I always tell my patients, I will never answer the question, am I ready for surgery?
Mhm.
Nobody needs surgery. It's when they start affecting that quality of life. And it means different things to different people. Some people want to just play with their grandchildren, bend down, take care of gardening, take care of their car, go
Mhm.
back to work. So it means very different things to different people. And I don't know what their quality of life is, so I simply cannot answer for them that you need surgery.
Yeah.
And most patients will come in and tell me when they're ready for surgery.
Yeah, and that's a great point. I tell my patients the same thing.
Mhm.
We're not necessarily treating an x-ray. They could have terrible
Mhm.
arthritis. And I tell my patients, I can sit here and tell you that you need a joint replacement,
Mhm.
but you're going to come and tell us when you're ready to have that done. Up
Right.
until that point, we'll do everything we can to make you
Mhm.
pain-free and let you live the lifestyle that you want to
Right.
live.
And that's the thing about x-rays, Brad. I've seen x-rays which are absolutely horrendous.
Mhm.
I just had a case the other day, which the hip was, I couldn't even identify where the beginning and the end of the hip was. And this gentleman was a roofer, and I have no idea still how he got on the roof to work. But he said it bothered him a little bit,
Yeah.
before, and now it just bothers him a lot. So he was ready for surgery.
It's,
And so
it's a strange phenomenon.
It
We
is
have
very strange.
terrible looking x-rays, and they don't have much pain. And,
Yeah.
and then you can have the flip side where they have mild arthritis and seem to have significant pain. So,
Exactly.
yeah, interesting. All right. Well, so moving on to the joint replacement and that surgical discussion, what are the benefits of a total joint replacement?
So the benefits is that, we talk about the arthritis, we talk about the inflammation, and one of the things that comes with it is obviously pain. So you get that pain relief. But the one thing we don't talk about is that arthritis, our natural cope mechanism of the arthritis is that when you have very progressive arthritis, the natural treatment is to lock up that joint.
Mhm.
So if you lock up a joint, it doesn't hurt, right? So we talk about the pain a lot, but there's also this loss of motion.
Mhm.
You would not believe how many people come to me with hip arthritis, and their biggest complaint is that they cannot put on their socks,
Yep.
right? So that loss of motion, then improvement in that motion, their pain,
Mhm.
improvement in pain, those are all big things when it comes to the benefits of the surgery.
Yeah.
And again, it's all about that quality of life. And that's what most people want, go back to that quality of life.
Yep. Well, so they're considering what should be considered then as they're going down that path leading to surgery? Are there requirements that have to be met? Do they have to have failed certain things in order for them to become a surgical candidate? Or from your perspective, what's kind of the process leading up to joint replacement?
And it's, this is different for everybody else, and, different type of arthritis. So the rheumatoid arthritis and some certain inflammatory arthritis where the x-rays may not look that bad, but they're in absolute misery, and they tried everything possible, and they simply cannot get better. I don't really have requirements. Again, it comes down to what they have done so far, and I present them with options, and they say, well, I don't really want to take the risk of surgery. Let's try this. So we go ahead and and I always start with the conservative management first, because like I said, the risks are the risks. So why risk it if you don't have to?
Right.
So we start with the conservative, and then we move on from there and progressively talk about surgeries.
Good. And then at Adina, as far as, do they have to reach a certain weight? Do they have to stop smoking? What are the requirements to make them an ideal surgical candidate, so that they have the best possible outcome?
Absolutely. And for us, what we care about the most is they're the best version of themselves. When you talk about medically speaking, we have, personally speaking, there are two things I care about the most: making sure you're the healthiest version of yourself. But what does that mean? It means that your lungs, your heart, your kidneys, everything is under control. Your chronic medical issues, someone has COPD, someone has, heart issues, they have stents. All those things are taken care of before the surgery. And then the other thing we talk about is the smoking. And I always tell all my smokers that the risk of infection goes up tremendously. So, I always wait until they pause the smoking, and then we go ahead and do the surgery, because that's the safe thing to do. Same with the obesity and overweight. We want to get them in a program where they can lose weight. And unfortunately, when you talk to some of these people, they simply cannot lose weight through exercise because of the arthritis themselves or itself. And so what we encourage is that you come to us. We will go into our optimization protocol, and our optimization team will give you the referrals and the tools that you need, so you can quit the smoking, you can you can improve that weight loss. And then once all that basic primary things are taken care of, then we focus on your overall health and see how we can improve that. If you have to go back to your primary care doctor, if you have to go back to a heart specialist, we do that and make sure that all of those things are taken care of before. And here's the reason why. The most important thing when you talk about surgery is making sure that after surgery, you're able to rehab that knee or that hip really well. And used to be that we didn't really do the best job with optimization, us as surgeons 10, 20, 30 years ago. And people used to be in the hospital for a prolonged period of time, usually week, 2 weeks, 3 weeks. And it would really cut into their rehab. So people wouldn't be able to get that knee range of motion, wouldn't be able to get that pain control like they needed. And so now what we do all that things before the surgery. And by doing that, now the only thing they really have to concentrate on is getting the rehab that they need so they can get better and get better quickly.
Good. So say, for example, I come in to see you, it's time for my hip knee replacement. You say, yep, let's go ahead and proceed with that. Walk me through what I would be doing from the step from your office up until that point where I end up in the operating room.
Sure. The first thing is always we go through evaluation. We talk about your goals. What do you want out of that hip? Can we do it surgery, without surgery? And the goal is always to do it without surgery if we can. But if we exhausted all those options, and you've seen quite a bit of this as well, we talk about surgery. And the surgical protocol is really me identifying their goals, what they want out of the joint replacement. I talk to them about their health habits. You could talk about smoking. We always talk about the weight loss. We talk about what the post-op rehab is going to be like. And then they meet our optimization team, and their role is to basically take their health, put it through our metrics and our certification and ensure that they are a good candidate. And if they're not, that's fine. We'll give you the tools to become the best version of you.
Right.
And then you can go and see your primary care doctor and ensure that, we communicate with them and how can we get you to that goal? How can we get you to the best version of you? Do we have to have a cardiology involved because something came up on the EKG? Do we need to get a pulmonology involved? And so it really is a multidisciplinary team, and really the center of that is you, the patient. And there's a lot of misconceptions and a lot of myths surrounding it, and people think the doctors are the middle of that, but it's really not. It's the patient. Once we do that, and we identify and you're a good candidate and you go through our education process, we go to the OR where you see our anesthesiologist, you see our OR PACU and staff, you go back to our orthopedic floor, who are the nurses are absolutely phenomenal and they know exactly what to do with our patients. We get you the physical therapy and then we go back and most people leave within 23 hours. And they continue outpatient physical therapy. And the one thing we don't usually talk about, and which is I find is the most critical thing, is the patient's family members. We find that people who have good support, and it's not always just family that you're born with, it's friends, the even church members,
Neighbors.
And though if you have good support and they can take you to rehab, they can take you to other places, those people just do phenomenal. And I've seen that multiple times throughout the last 10 months.
That's an interesting point.
Yeah.
Good. Well, we're going to move on and talk about kind of specific hip arthritis. And so what would the surgical procedure that you do to overcome hip arthritis?
So if you look at the video right here, the hip arthritis is really, the hip is a ball and socket joint. And the socket is in the pelvis. The ball is at the end of the thigh bone. The white stuff that you see is the cartilage. That's the smooth, shiny surface that you see at the chicken bone. It provides lubrication to the joint. It protects the joint. As we go through that wear and tear process that we talked about, we talk about arthritis, and that's what it is. Those cartilage starts going away. You get cysts. You get dense bone because now you have bone-on-bone articulation. And at this point, you're basically driving around without tires. And we know what happens when we drive without tires. The surrounding tissues just simply don't like that. And so what it does to do, it makes that inflammation, which causes the pain. And that cycle just repeats itself. And so what we do with the hip replacement is we remove that bad socket. We put a titanium cup. We put a rod that goes into the thigh bone, and then you have a nice pink ball with the plastic, and that's a total hip. And the benefit of doing that total hip is, again, you are removing everything that causes the arthritis so that now the joint can function like it's supposed to. And by removing all those extra bones, that's limiting your motion. You're free to move in what you're supposed to move.
Okay. And as we move down the leg then, so for a knee replacement, knee arthritis, what surgical procedure do you do to overcome that?
And there are two main surgical procedures that I do. I do partial knee replacements and total knee replacements. And when you talk about the knee, again, you have that nice, smooth, shiny cartilage at the end of the thigh bone up top, and then you have it at the beginning of the shin bone, and that's the knee. And then you also have the biggest cartilage between your kneecap and the thigh bone. And again, as we go wear and tear, or you have rheumatoid arthritis or any of the other or inflammatory arthritis, you can get wear and tear. Now, this particular wear pattern, you can see it's mostly on the inside part of the knee. Now, there are three parts to the knee. You have the inside part, which is the medial part, the outside part, and you have the part that's underneath the kneecap. Now, all those are considered partials. Okay, so this particular picture shows that it's on the inside part of the knee. And if the rest of the knee looks fine, then we leave it alone. And so if you talk about partial knees, what we do is just address the inside part of the knee, and you have you put a metal cap at the end of the thigh bone, you put a metal plate on the shin bone, and then you have a plastic in between. Okay, so that's a partial knee. The good thing about this procedure is that you can see that the ACL and the PCL and most of the knee is intact. And when you leave all of that intact, Brad, it's the nerves are intact as well. So people will tell you that it feels more like their normal knee because you're not removing a lot of their knee. Whereas, when we talk about the total knee, the total knee is really you're removing the arthritis that's there, and the arthritis would be in the inside, the outside, the underneath the kneecap. So you remove it from the thigh bone, the shin bone, and you replace it with metal and plastic. And this is the difference between the partial and the total, because you're removing most of the structures in there. Most people will say, their pain is gone, their motion is great, but it doesn't feel like their normal knee.
Okay.
Yeah. And for most people, they don't get bothered by that because, again, pain is the most limiting thing that they have.
Right. And with the partial knee replacement, how long can a patient expect to go with that partial before they might need another surgery?
Sure. And this is a very common question that I encounter pretty frequently. The rates of complications is about the same whether you do partial or total. It's about 1% per year. And so I tell my patients that 10 years down the road, 90% chance that you're doing great. 20 years, 80% chance you're doing great. There was actually a really good study done from the Oxford group for looking at partial knees. And that study showed that it was 97% survivorship at 10 years. So it's a shorter surgery, less chance of infection, and people do well.
Yeah, sounds like it.
So I wouldn't be hesitant. And I always tell my patients, when I do a partial knee replacement, I always look at the other side. And if something on the other side looks bad to me, then we go to a total. So there's no taking chances.
Right. They don't want to have to come back for a second.
No.
Second surgery.
You're already there. You look at the other side, and there's no better MRI than your ocular MRI.
There you go. All right, we're going to jump back up to the hip. And so when we talk about total hip replacement, there's different approaches to the hip. There's the anterior hip approach, lateral, posterior hip approach. So if you would, just talk a little bit about those different approaches there and what the difference is between them.
Sure. And so the approaches are basically how you approach the hip. The anterior approach, you go through the front. The good thing about the anterior approach is a muscle sparing approach. So you go between the muscles. So you're not cutting the muscles. You are stretching them, but you're not cutting them. The lateral is you go from the side, and again, it's anterolateral. So you go through the side, but you go through the front as well. Good thing about that, the one thing I worry about the most is instability, and the lateral approach has probably the lowest risk of dislocation out of all the approaches. And then you have the posterior approach, which you go through the back, and that is probably the most common approach that we still do in this country. And we've been doing it for decades, and it works great. When you look at the difference between the anterior approach versus the lateral and the posterior approach, the benefits really in that first 6 weeks. The pain, because you're not cutting muscles, your recovery is simply much better in those first 6 weeks. The data shows that, at 6 weeks, there is no difference between the anterior, lateral, or the posterior approach. But really, it's in that first 6 weeks where patients really appreciate it.
And then typically, how long does it take for a patient to recover from say, the anterior hip approach? Is it different between the approaches too?
Correct. And there is. And for anterior approach, it's really patient dependent. And we all have patients who accelerate because they're young and healthy. And there are some people who have a lot of medical comorbidities, and they just take a little bit longer. But in general, most people are on walker or cane for that first week. They transition to not using anything with the anterior approach that second week, and they're usually walking around by second, third, fourth week without any issues.
Okay.
And that's the difference between that and the lateral and posterior approach, where you do have a little bit more longer recovery, and it really takes 6 weeks for them to recalibrate themselves.
Okay. And then how do you decide which patient is going to receive which approach?
I would say a majority of the patients I operate on are candidates for the anterior approach. But there are some complex cases, some deformities, that just not amenable to anterior approach. If you need to do something a little bit more extensive, you have to take down and reconstruct by taking away a lot of good bone, then the anterior approach. And there are some people around the country who can do it, and they're, I find that the other approaches are a little bit more extensile.
Okay. Well, I think, can you provide an example of cases where you've performed the anterior hip approach? I think
Sure.
we have an example
Sure.
video.
This is a very nice gentleman that we had, and he was unfortunately plagued by that, what we call arthritis. Now, if you look at the left side of the screen, you can see that normal hip joint where we showed that little cartoon before, where you have the socket and the ball part, and the space between that is the cartilage. And that's the smooth, shiny surface that you see on the chicken bone. Now, I like to look at both sides so you can clearly see which side is not the good side, which is the patient's left side, which is the right side on the screen. And unfortunately, this gentleman just was unable to walk, unable to ambulate. He was using his cane. He couldn't put on his socks. He couldn't just do his daily activities. And he was a very young gentleman. And to take away something like that was crippling for him. And so if you go to, so he came in for the surgery, and we went through all the non-operative factors, but he was clearly bone-on-bone arthritis. And so we opted to go through surgery, and we have a video of him walking before the surgery. The video that you're going to see, you can see him limping. You can see him using the cane. He was just unable to perform what we like to call normal gait. And you can see that.
Germ-proof your car with Pharma disinfectant. Kills 99.9% of bacteria and viruses.
Okay, and that was a video that was 24 hours after the surgery, and he already had an improved gait.
Yeah.
And the next video that you're going to see is him at his 2.5-week visit when he came to see me in his first follow-up.
Okay.
You said 3 weeks?
3 weeks.
Yeah, and so this is where the anterior approach really shines. It's a young patient who's crippled and who just wants to go back to his activities, and it's because it is a muscle sparing type of approach. It's they just simply do better in that first 6 weeks.
Yeah, that's amazing. I'm sure he was
very
very happy. Yeah. All right. So we went through total hip replacement. We went through total knee replacement, partial knee replacement, total knee replacement. Why should people choose Adina for joint care and joint replacement surgery? What should be the draw for them?
And it's the people and the providers that exist in this place, and part of that is the quality that comes out of this place. We have the gold seal of approval. We have this advanced certification from Joints. We had the government essentially come to us and evaluate us, and that's what it means to have that kind of certification. And it's the high level of that quality care. The utilization of the best practices. Like I mentioned before, we have multiple multidisciplinary team that's there to provide care for you. All the way from beginning of when you see us in the office, our LPNs, our MAs, and all the way through to the end of surgery. And even afterwards, when you go to physical therapy, everyone's there to help you. And so it's really that multidisciplinary team that exists here, and the way it works is just amazing.
Yeah, that's great. Now here at Adina, we do lots of robotic surgery. Many surgical subspecialties and general surgeons use the Da Vinci robot.
Mhm.
And not to be outdone, the orthopedic surgeons, they have a robot as well. The
Mhm.
one we use here at Adina is the Mako robot.
Correct.
So the question that many people have, is it the robot itself that is doing the
Right.
surgery?
And we always call it the robot-assisted surgery. So the robot allows us, just like any other tool, it allows us a greater degree of data that we get during the operation, before the operation.
Mhm.
So what that allows us to, if I want to put a component in a certain position, 1 degree off, 2 degrees off, because it's going to balance your knee perfectly. If I want to put this so that you don't dislocate or create instability in your hip, the robot allows us because it is very precise. But at the end of the day, we still control the robot. We still control where we want to put everything and how this the deformity is going to change the stability, how it's going to, how do we need to manipulate the robot to do what we want.
Sure.
So it is a robot-assisted surgery in its truest sense.
Yeah. So it's the robotic arm, but the human touch, the surgeon's
Correct.
touch is still a very important part of the actual
Absolutely.
surgical procedure. It's not a self-driven process.
Absolutely.
Okay. So I think we're going to move on now at this point to the Q&A session. So if those people who have entered some questions, we'll start taking those now. All right, first question that we have, will my leg be shorter after my hip replacement?
And this is a very common, sir. It's a very common question. What I tell my patients is that the most important things when it comes to your hip replacement is making sure it's stable. And if it's not stable, simply the patient's not going to trust their hip replacement. And then what's the point of doing a hip replacement? And so sometimes that stability comes at making that leg a little bit longer. It's really hard to make someone short. I can tell you that. It's very easy to make someone long. And sometimes you have to make them long to make sure that hip is stable. Now, we avoid that in almost all the cases. We have special tools, such as the robot, to tell us how much longer that patient is and if it's acceptable or not acceptable. So we have multiple different tools that prevent us from making one leg longer or not.
Sure. And which patients would get to use the Mako robot for their surgery? Do you use it on everybody?
So I leave it up to the patients. There are certain patients who have very vast deformity, who have big spinal, and this is a hot topic that occurs in joint replacement now. How does the spine affect the pelvis? And if the spine is manipulating the pelvis, where now it's creating instability in hip replacement, and so I use the robot in those cases in someone who has those very big spine fusions, someone who has very bad back, and I want to make sure I want to put that cup and that socket in a place that I want.
Okay.
And so sometimes, I do tell them that we have the robot that will allow us to do that. It's a tool that allows us to do that. And then the other things are, if the patient comes in and they want a robotic, then we'll go ahead and do robotic.
Okay, good. Next question, what equipment and brand of equipment is used during a total hip replacement?
We have many different brands. Like I said, we have the Mako robot. That's the robot that is created by one company that we use, and obviously the implant that comes with that. The other one are non-robotic, and I actually use multiple different brands depending on what the needs of that patients are. Every brand has different neck angles, for example, with the hip replacement. Every brand has different heads. And so whatever fits the anatomy of that patient the best, I'll use that. Because the goal is to recreate that biomechanics, we call it, and get that hip as normal as possible.
So you're not using just one brand. It sounds like you're tailoring it to each patient.
Absolutely.
Specifically. All right. Next question, it's actually a two-part question. Can you live a normal life after a total hip replacement? And the second part of that question is, how long can I expect the recovery to be after having that hip replacement?
Okay. The goal of doing any of these surgeries is to go back to your normal life. And and that's truly the goal. The you know the recovery process is really dependent on how bad the deformity was. As we explained before, the arthritis is very unique, and your body's mechanism to overcome that arthritis is to lock up that joint. And what we find usually is that when your joint is locked up, your muscles surrounding that joint become a little bit weaker. And so when you now become free from that locked joint by doing a hip replacement, you have to rehab those muscles well, because as we know, anyone who's ever lifted anything in their life, it's very easy to lose once you stop working out. So it's one of those things that, it could be 2 weeks, it could be 6 weeks, it could be 3 months sometimes for those things to recover.
Sure. And the next question here is, where is Adina Bone and Joint Center located?
It's in Chillicothe. We have multiple different locations, and our sports colleagues are in multiple different locations, Jackson and Washington Courthouse, and but our main central campus is in Chillicothe, and so I'm here.
Yep.
And
right in Chillicothe, attached to the actual hospital in a building called the Adina Health Pavilion.
Correct.
And we're on the ground floor there. And yes, we are in the region, as Dr. Patel was saying, so we can be found in Jackson, Waverly, Circleville, Greenfield, Hillsborough, and Washington Courthouse, in addition to our Chillicothe location. This next question, we'll see about it. It says, are you familiar with a condition called Forrester's disease, and have you treated any patients with it? I'm not familiar with that.
I'm not familiar with it too. There's a lot of synonyms for those diseases.
Right.
Might be a technical term for it.
Yeah.
But I'm very curious to know.
Yeah. So we apologize. We don't have a definitive answer on that one. We answered that one. All right. This next question. I've been going to a chiropractor for my shoulder pain. What does a chiropractor do that is different than what Adina can do? Is it time to see a surgeon for my shoulder?
They're very similar, and there's a lot of overlapping between the two specialties. The way we approach it is a little bit different. The chiropractic is a little bit more holistic, using your body towards controlling that pain and inflammation. Ours is more, a little bit more medicinal approach, I would say. And then also we want to make sure that you go through physical therapy, you rehab it well. We talked about all those conservative management that we talked about before. I think people benefit from both.
Yeah. And as to when it's time, I guess if you're not where you want to be, then it's always good to get another opinion.
Yep.
Next question is exercising good for my joints, or does it actually hurt them?
Nope. I always tell my patients, it will hurt you, but you won't hurt it. So you can always continue to exercise, and the goal is to be active.
Yeah.
And so, yes, it may hurt you, but we'll advise you on how to take those anti-inflammatories, those pain medications. I always say, if you're going on a big hike, just anticipate that you're going to pay for it the next day, but expect for it and look for it, and then you won't be surprised.
Yep. I tell patients too, basically do what you feel capable of. Exercise is good, but you got to find that balance of what makes you more painful afterwards, and probably not do that type of exercise. Next question is, what is the typical length of hospital stay for total joints?
So most of our total joints, and this is a very big phenomenon, it's been changing every year, I feel like. Typically, it's 23 hours for us. Most people are discharged within the first day. Like I said, it really depends on how medically complicated you are, and if there's something that we need to control before the surgery, or even after the surgery, it may take 1 to 2 days. The other thing that plays a little bit of a role is how much family support you have. So people who have good family support and able to be discharged home tend to leave a little bit earlier, but if they end up going to a rehab facility or other facilities, those do take a little bit of time based on bed availability and based on how well you're performing in the hospital. And so most people do leave within 23 hours.
That's good. Yeah,
Mhm.
that's quick. So for those that may be just joining us, I'm talking with Dr. Neil Patel. He's an orthopedic surgeon at Adina Bone and Joint Center. We're in the midst of talking about joint replacement, hip replacement, knee replacement. What is arthritis? What are the types of arthritis? If you're just joining us and want a question answered, feel free to submit those right now, and we'll try to get those answered before the end of the program. This next question, do I need a certain type of bed or chair after my hip replacement? And what type of things should I consider for when I return home after the hip replacement?
And this is a very good question, actually. And this is what, when you come to Adina Bone and Joint, and when we see our evaluation, I mentioned before very briefly that you talk to our optimization team, and part of what they assess is what kind of requirements you'll need for home. So, if you have stairs, if you don't have stairs, if you have a ranch house, what kind of toilet seats you have. So whether or not you need commode, whether or not you need a walker, whether or not you need a cane, we will assess the needs that you need, and then we'll provide it.
Okay. This next question, are infections common after a total knee replacement or a total hip replacement?
So infections are not common. Like I said before, when I said, after total joint replacement, the rate of complications is about 1% per year, which includes infections, which includes the aseptic loosening, where so on and so forth. But infections are very devastating when you talk about total joint replacements. And I do everything possible to ensure that the risk of infection goes down. I always tell my patients that infections after a total joint replacement is like getting cancer. What that means is that the amount of surgeries and post-surgeries you have to do, the amount of the antibiotics and repeat surgeries, it's devastating for both the patient and myself. And so the best treatment for it is really to prevent it. And that's where this whole optimization thing really came about. And that's why I really make sure and ensure that most of our patients who are smokers, we give you the tools to stop the smoking before the surgery, at least 4 to 6 weeks. If you are someone who's overweight, we'll give you the tools to decrease the weight before the surgery, because all those things are related to infection. Every one of those things that you can control and decreases the risk of infection. That doesn't mean there's no such thing as 0% infection, but if there is one, now we know and what to do about it, and we can control it.
So it sounds like beforehand, you're making sure that they're an optimal surgical candidate. And then obviously you take precautions during the actual procedure. Is there anything that they can do once they leave the hospital just to help prevent an infection?
Sure. And the biggest thing you can do is making sure that what you were doing before the surgery, you continue to do. So not smoking, controlling nutrition. One of the most important thing when it comes to post-surgical outcome, I think, is nutrition, because it affects wound healing, it affects your recovery, and everything that goes in with relates to that. So you may think that you're obese and you have enough nutrition, but often we find that those people are actually malnutritioned. And so nutrition is a very, very important aspect. And I tell them, eat those high protein meals, eat those things that will make you feel better and good. And the whole point of this surgery was to be active. So participate in your physical therapy, take care of those wounds. And, I provide a whole sheet of things that we look out for. And, if you find it early, we can address it. And usually you haven't had any issues with it.
Sure. And after total joint replacement, what does physical therapy look like, and how soon does that physical therapy start?
And this is very different between the knees and the hips. The hips are very resilient to physical therapy, I would say. They don't require much physical therapy, rather. And the reason is because most people are stiff or they're locked in when they have a hip arthritis. And when you do the surgery, the muscles surrounding the hips, they just don't get stiff like the knees do. And so a lot of them will go into their activities of daily living, and some of the centers around the country don't even do physical therapy. I find that, with our patient and our population is that, because they have those hips that have been immobile for so long that the muscles surrounding it are just weak. So I always tell them to participate in the physical therapy with regards to the hip,
Right.
and just to get that strength back. And most people don't need much for hip replacements. With regards to the knee replacement, it is the complete opposite. And I'm very particular about the knee replacement. The most important thing you can do is go to an outpatient physical therapy wherever you are and get that knee moving, because you are not going to like your knee if it's, if you don't have that range of motion. If you cannot get your knee straight, you're going to hate it. If you can't get your knee back, most men don't care, but most women will. And so the physical therapy becomes a very, very key aspect when you talk about a total knee and partial knee replacement.
Yeah. All right, let's see if we have any more questions. Yes, we do. All right, the next question is, do you go home on medications to prevent blood clots after your total joint replacement?
We do. And blood clots is also one of those things that we take very seriously. So depending on your health conditions, it could be a chemical, something to help the blood clots. And it comes in many flavors. It could be something like Xarelto, or something benign like an aspirin, baby aspirin, twice a day. And a lot of it will depend on if you're on blood thinners beforehand. If you're on blood thinners beforehand, then you just simply go back to your home medications. If not, then I do at least 6 weeks of blood clot medication. And then the other thing I always send patients home with is we call them SCDs, sequential compression devices. They go on your calf, and most people who have been to the hospital have seen them, but I usually send my patients home with them. And so those also help prevent blood clots. So the combination of two works incredibly well.
Good. Next question. What's your best advice for someone who is hesitant to get a hip replacement?
I mean, what I would say is, if you're hesitant about hip replacement, you just simply cannot, you have to be all in when you talk about it, surgery. It is your body. It is, and it just doesn't do well if you're hesitant. So if you're hesitant, we'll just continue to do those conservative management. You don't have to do surgery until you're ready, until you say, that's it, I can't take it, and I need a hip replacement. Because it's one of those things that if you are not mentally prepared for it, you are not going to do well. You just are not. And so I always tell my patients again that, you have to be all in when we talk about a surgery, because the most important thing is not surgery. My part is maybe 1 to 2 hours. It's really those 3 months after the surgery that makes all the difference. Okay. So that's the thing about the hip replacement. A lot of patients of mine have come back though and said, the biggest complaint they had with the hip replacement is that they didn't do it sooner.
Yep.
Because out of all the operations, I would say, when you talk about the hips, the partial knee, and the knees, the hips do the best. It's actually probably the number one operation when you compare all the operations that we do in any surgery, is the hip replacement.
Great. Next question. Is it true that the longer I wait to have a hip replacement, the longer my recovery will be? And I think you touched on that a little bit, the more severe deformity
And
you have
yes and no.
might make the surgery a little bit more difficult. You might not be able to do the anterior hip approach because of the deformity.
Right. And that's, you have to take that with a grain of salt. I mean, it's really not that your recovery is going to be that long. And in the grand scheme of things, you're talking about 1 to 2 weeks to maybe 4 weeks. And, again, in the grand scheme of things, it's not that much longer.
Yep.
It's whatever it takes. And everyone progresses a little bit slow depending on their age, their prior activity level, and how motivated they are. And so those things matter more, I would say.
And this question, are you accepting patients if I think I need a total joint replacement?
Always. Doors are always open. And like I said, we have a whole team of providers. We have obviously Dr. Strauch, myself, and everybody in the Adina Bone Joint providing care. So we work together, and we'll get you in, and
Yep.
you'll be evaluated.
And I think, I don't know if intermittently, I mean, there's a website, and at the end here, we'll give you a phone number that you can call for our office. And then I think we'll finish up here with our last question. What type of shoes, if any, will I need after a hip replacement? Is there any specific?
Anything that is comfortable, nothing that will make you trip over anything. So the worst thing that could happen is you fall after hip replacement. And so, you use a walker, you don't want any kind of trip hazards. So no high heels, especially for
Good
men.
advice. Yeah. Good advice. Well, thank you, Dr. Patel, for the information on arthritis and total hip replacement, total knee replacement. Very informative. Thank you, audience, for joining us this evening. Thank you for the questions that you did submit. We hope it was informative for you. If you do want to schedule an appointment, you can call Adina Bone and Joint Center at 740-779-4598, or you can go onto the website, www.adina.org/appointment, and you can submit for an appointment there. But thank you again for joining us, and have a good evening.
All right. Thank you so much for having me.